the introductions. I would like to start and just introduce the day. So this is the 7th annual Humphreys Pediatric Neuroscience Day, and it's being held in honor of Peter Humphreys, who's with us here today. And Peter, as I think most of us know, maybe some of the more junior residents may not, has been a real founding member of the Division of Neurology and a giant here at CHEO in helping to establish both neuroscience as well as comprehensive pediatric care. So we have instituted these rounds in his honor to That's right, exactly. There's a connection there with McGill, Joe is shouting out. And so we've put these rounds in place in his honor to acknowledge and recognize the terrific contributions that he's made to our division and to the hospital over the years. And then I'll turn things over to Pranav Chakraborty, who will introduce our speaker.
Yep, thanks. So also as part of the day, the Division of Neurology always invites a keynote speaker for the morning, and it's always someone who has made and is making a significant contribution in the areas of neuroscience. So it's a very lucky thing for us that neurology is able to bring such speakers to speak to us about their work as relates to pediatric neuroscience. So this year it's Dr. Ming Lim, and he is a consultant pediatric neurologist at the Evelina London Children's Hospital and is professor in pediatric neurology within the Faculty of Life Sciences and Medicine, King's College in London. He's head of Children's Neuroscience Department, research lead for the Evelina Hospital, and Associate Director of the NIHR, National Institute of Health Research at Guy's and St. Thomas NHS Foundation. I always find the NHS Foundation Trust hard to say, clinical research faculty. He and his team are leaders in clinical care and research of children with neuroinflammatory disorders, with over 200 total publications in the area. And so today he's going to talk to us about the evolving area, the changing face of pediatric neuroinflammatory disease. So thank you for joining us, and the podium is yours. And if you just stay in front of the computer, people online will be able to.
Excellent. And do you want me to stop the floaters out there as well?
Rachel will do that.
Great. Yeah. Okay. So thank you very much for the invite. And I've spent 2 days in Ottawa, and it's thoroughly enthralling, both the temperature as well as the scenery as such. So I'm based in London, and there are two big children's hospital or pediatric neuroscience center in London. I come from the one south of the river, which is the Evelina, and the other one's more famous, and I'm sure you've heard of that. It's Great Ormond Street Hospital. And in the UK, there are 23 pediatric neuroscience center, and the reason to mention it is because most of the work that we do, particularly neuroinflammation, is in collaboration with all the neuroscience center. It is rarely a singular center. And as you can see, the rarity of the conditions and the sort of breadth of sort of collaboration is what really makes this field interesting. So these are my disclosures, if it will make me move on. Sometimes it's frozen a long time, yeah. And it's going to be quite simple. The themes are rapid diagnosis, as you know, initiation of management, and more latterly, as you try to treat sort of more effectively, you've really got to try and work out whether you're treating inflammation or whether the pathology is due to a neuro sort of biological reason. So you wouldn't flog a treatment just because you think there is a primary inflammatory cause as such. And then there's sort of evolving mindset. And to be honest, most of you in Northern America are the ones that have been, pushing these sort of themes forward of early treatment. So it may not come as surprise to you as it does in sort of the European nations, where we tend to do the stepwise sort of escalation sort of process. But you'll see, some of that today. So I can't start a talk on neuroinflammation without crediting these three people. And if any of you know all three, you've been taught really well at university. So these are the three key people. Paul, I know him on first ground, term, the adaptive immune system, and his counterpart, the innate immune system. And in their lifespan, totally was at loggerheads with each other, disagreeing that, the other part of the immune system existed. And it's only like 100 years later that Ralph Steinman came in. Some of you would be familiar with his work. He described the dendritic cell and hence unifying, the two sort of types of immunity. And all three won the Nobel Prizes in their lifetime for their contribution. So very eminent people. So what did they tell us? It's all very simplified in 2 minutes over a lifetime's work. So the innate immune system, as you know, it's very, very rapid. It's not very specific as such, by contrast to the adaptive immune system, where it is, despite there being a time lag, is actually augmented to get rid of the virion, almost certainly from the first, sort of exposure when you had the innate sort of upregulation as such. They have different effector cells. A lot of you will be familiar with them. And different means that they communicate, i.e. these are the humoral sort of responses. And for us in autoimmunity, it's the antibodies that, feature a lot, but not forgetting that there are T cells, et cetera, et cetera. But as we start to recognize these, there are cells that have characteristic of both. So some of the more innate type cells like the NK and gamma delta, but also appear to have memory. And they sit in places like tumors, for example, in the NK cells, and gamma delta in your sort of mucosal sort of regions, purely because they need to be there, because that's the biggest interface between the environment and the immune system. And this is the dendritic cell that I mentioned, already. So in the brain, it is a little bit different in that for your innate immune system, you've got slightly more specialized cells, the microglia and the astrocytes. The microglia, as they become activated, retracts these sort of dendrites and becomes more amoeboid to get to a more macrophage sort of level, so they can chomp up material that requires removal. And the astrocytes does the converse. They hyperramify, almost certainly to prepare for repair, but also ultimately to probably reduce excitotoxicity by increasing surface area of contact with the environment as such. And all these molecular effectors have one prime role. They try to recruit the adaptive immune system systemically to actually repair and improve the milieu for recovery as such. It's a physiological process, inflammation. And you have that in a primary neurodegenerative condition, whereby destruction causes a secondary inflammation. And there are many examples now, like in Alzheimer's. In lots of the childhood lysosomal storage disorders, there's definitely a very significant inflammatory component, sometimes to the extent that people have even treated those patients. So in Batten's disease, fingolimod is currently being used to reduce the inflammation by sequestering lymphocytes outside the brain as such. And then of course the other is where you have a primary autoimmune condition whereby you get secondary destruction in the neurons. And often when orchestrated, it creates this circus of inflammation that is difficult to disentangle whether it is just purely innate or definitely sort of adaptive as such. Just a couple of minutes on immune surveillance, because we'll come back to it at the end as something that what we have learned and might develop a little bit further. From early tracking studies, and these are two nice reviews, we know that every antigen that is presented through almost certainly through the choroid plexus tracks through the arachnoid granulations and then passages through probably the ethmoidal olfactory bulb into your deep cervical lymph nodes. So people are biopsying the cervical lymph nodes as a means to understanding what's happening in the brain instead of biopsying the brain as such. As I said, we'll come back to that. And I suppose if you were planning an immune system or surveillance in the brain, what you would have is carefully placed receptors to not recognize naive cells. So only pre-primed cells will get in, otherwise it will create chaos. And then they'll find its way to areas within the brain where your sort of macrophages would be, and this could be in your dural and also in your Burkhoff or perivascular sort of spaces. And this is the basis of sort of immune surveillance. And then about 10 years ago, there was some very nice tracking studies introducing the concept that they're actually lymphatics in the CSF. And some of you may be familiar with the evolution of this to glymphatics as well. We're not going to have time to talk too much about that, but it's just the notion that as we start to think of the brain, we start to think of the brain now as almost like a lymphoid organ as well, where certain cells can sequester and maybe have follicles, particularly in the arachnoid matter, that is producing antibodies, producing cells as well, as opposed to everything just coming in systemically as such. Cannot talk about neuroinflammation without the blood-brain barrier. And these are two very nice reviews, which are essentially unchanged, except that the application of the knowledge of the blood-brain barrier has gone up a lot, particularly in latter years, in trying to get advanced therapies, into the brain as such. So I'm going to just want to highlight three bits there. As you can see, the tight junction is what is the usual mechanism, i.e. it's just opposed, and certain sizes will get through, but most molecules over 40 kilodalton, which is the weight of albumin, would not sort of get through the blood-brain barrier. Then what you really need are transporter molecules. So we've heard about a lot of those. There's glucose transport, there's transferrin, etc., etc. And the thing to mention here is the neonatal FC receptor. And many people don't recognize this or don't realize this, at least in the FC receptor literature that is becoming very, very popular because of treatments, particularly in myasthenia. Now, if you think that the role of the FC receptor here is actually to remove antibodies from the abluminal component to the lumen, so it excludes all nasty antibodies from the brain outside, I would certainly caution the use of a lot of these treatments or FC targeting in CNS disease, or at least you've got to significantly consider that. So the blood-brain barrier, as I said, are other sort of key components there that have been utilized, like the integrin receptors in natalizumab, etc., etc. Two concepts to take away from today is that inflammation is physiological, and very similarly, CNS autoimmunity has a protective role. It's sort of a protective role in the sense that you have to get rid of a damaging brain or a damaged brain to be able to allow for repair or recovery sort of downstream. On your left here is the brain model, and on the right here is the spinal cord model. So spinal cord injury, if you replete your C4 regulator cells, and it's best illustrated in this picture here right at the end. I'm not sure if you can see my cursor there, whereby the the regulator cell depleted model does not remyelinate as well, and there are many other examples as such. So you need to get rid of the damage already to be able to repair, as such, and that's probably where the primary benefit of inflammation comes in, or neuroinflammation comes in. And for many years, we've been worrying about, what is the threshold? When is it friend? When is it foe? And this sort of concept really sort of is probably the best one to hold on to at the moment, in that your phenotypes of microglia can be passage from one type to another type, and they have different, sort of chemokines, and they have different roles, as you can see there, sort of cytotoxic to repair, and then sort of an immunomodulatory role. It goes through phases, the popularity of this, and it's sort of coming back in fashion again, having been in fashion about 15 years ago when I was doing some of that work. So today we're going to be talking about when things don't go right, and this is the neuroinflammatory syndromes that we generally see. And I'm hoping that at the end of this you would take away these two concepts of trying to split inflammation to sort of an autoimmune phenotype. Remember, I already alluded to that sometimes it's not that easy, and sometimes it may be productive to do so, but there are certain situations where it might be important to try and think what the primary mechanism is at the outset. And then the second group are the autoinflammatory encephalitis. Up till 5 years ago, most of the autoinflammatory encephalitis have been parked in the autoinflammatory genetically predetermined sort of conditions. So these are all your autoinflammatory conditions. But I think we should start thinking about them quite similarly, because some of the therapies are not dissimilar, as such, i.e. the specific targeting of the innate immune system, particularly quickly early on, and we'll talk a little bit about that. Okay, so that's all we're going to talk about in terms of the sort of primers of immunology, sort of, etc. Now is the clinical bit, so hopefully some of you would sort of wake up, or now. So I know sort of I was tasked to think a little bit about sort of autoimmune, sort of encephalitis and also, sort of MOGAD. But over the years, there have been so much sort of overlap that I thought to try and do it sort of condition by condition. One, is going to take me way too long, and two, I'm expecting that, from sort of an institution like this, you would know so much about this already. So I'm trying to theme them, all together and see if that helps, come across treatment. So early recognition, I think, is exceptionally important. And as conditions become more and more recognized, it would be hard to imagine that any of us would not recognize autoimmune encephalitis now, particularly the NMDR, which is typically, polysymptomatic, and, children get, pretty unwell as such. In a child that presents with a sort of mixed movement disorder acutely in a previously well child, again, this is highly unlikely that, it's going to be missed. But I just wanted to show you two children that have presented in two different epochs. And I'm going to show them simultaneously, because the first one is the early sort of presentation that you might have seen 15 years ago, where you might not have recognized this, and the child's gotten to this level of, severity. Whereas in this currently, for most children that present, oh God, it's flipped the other way, I'm sorry, it present with a much sort of milder phenotype. So you recognize the polysymptomatic phase, the movement disorder, fairly early on. You initiate treatment, and less children, get to that severe state. Of course, you still do get some children who present with a very severe, polysymptomatic encephalopathy, and 30% still go to intensive care. But by far, we pick them up sort of a lot earlier. So we have made a change, in that as such. And the change really, oops, let's hope not to end the show. And the change has also come in recognizing that children need to have slightly sort of different criteria. So I'm not going to mention sort of MS here, because it could be a whole hour if we were to talk about sort of MS criteria, and Daniela's laughing at me already, or smiling at me already. But so let's start with sort of, and there are two criteria essentially. First, proposed by Grouse, called the Grouse criteria, which is an adult-based criteria with some pediatric considerations. It's more of an iterative criteria as well, meaning that you start with excluding conditions that are excludable, like NMDR, limbic encephalitis, and a few things. But a lot of things of those are not as applicable to the child, because one, children, the frequency of limbic encephalitis is so little. So why do you want to spend so much time trying to exclude that right at the beginning? So that's the history of why the Colucci criteria was proposed by and spearheaded by Russell Dale, who's a colleague that some of you would have, well, must have read about. And it's on the notion that it's easier to think of the childhood presentation right at the front, before you even need to distinguish between NMDR and the others. And because children are more polysymptomatic, you allow for more symptoms, and it's 2 out of the 7 symptoms that commonly appear in autoimmune encephalitis. And if you suspect that, you should begin to investigate, and some would argue probably even try and think about initiating immunotherapy before that. As you investigate, if they do have the confirming autoantibodies, you would say that they have definite autoimmune encephalitis. So this is your NMDR, your limbic encephalitis of sorts with LGI1, Casper, etc., etc. But of course, if you don't, that's when most of our times, we get called. And it's to afford you to use some of the paraclinical criteria to make a diagnosis of probable. And the difference between this and the adult criteria, which is the Grouse criteria, is that the Grouse says you have to use 2, and this one says probably use 1, because many reasons. In children, you sometimes don't get the full CSF, you don't get the results, you might not repeat it. And there are some examples of where the response may happen a lot later on, or you may not get as inflammatory a response. But all that means that you would allow for one criteria. Of course, immediately looking at that criteria, you would know that it's sacrificing or specificity for sensitivity, and that's what you would expect. And of course, many years to come, if you identify the antibodies, you redesignate the conditions, and I'll give you some examples of that. And a lot of us were applying those criteria, which was, as you can see there, published in 2020, recognizing the pitfalls and sort of making sure that patients with a probable or possible diagnosis are redesignated so they don't get lifelong immunotherapy because someone once thought that it was that condition and it's something else. And it's the recognition of that that really made this a Spanish group. And Thais, who worked with Joseph, but now runs the lab herself, published this very recently, looking at the utility of both criteria. I'm only going to do the Cholucci one now. So if you take the whole Spanish cohort as such, these were the numbers at the outset. And you might not be able to read it as much, but it just to demonstrate to you our affirmation of what you see in clinics as the differentials of not making the criteria. So the three key points there are, there will be some children with autoimmune encephalitis. These are the predominantly monosymptomatic ones, those that are not encephalopathic, and those whom you found to be positive will be defined as that. So you would miss it with this criteria. So these are the non-AE presentations of antibody CNS mediated sort of conditions. You investigate them and you find that maybe in this cohort, which is the most comprehensive today, 20% will have confirmed autoimmune encephalitis. And with the prior clinical test, there were about 25% of them did not have any of the positivity of the paraclinical test. So, and you can see there that more than 90%, 97% did not subsequently have an autoimmune, sort of condition or inflammatory condition that is AE. So I'm pretty confident now, as I had been, that if the paraclinical examination is normal, you're pretty confident to say it's not autoimmune sort of encephalitis. So that's a good take-home message, I think. But of course, if it's positive, you still got to be aware. Remember, we said that the specificity will not be there. So as Dave alluded to there, at least 30% do not subsequently have AE diagnosis, although they might have an inflammatory diagnosis. So those are markers of just inflammation in the brain, may not be specific, to AE. So there's a lot more to digest in that paper, but I just wanted to highlight that to you, and I think it's a very important paper for our clinical practice, as such. And this is really down to sort of whether we call this a mimic, a misdiagnosis, or one that presents exactly that autoimmune encephalitis that isn't. It's quite mixed up in sort of the literature. But it's to highlight to you that a primary psychiatric diagnosis and functional neurological disorder in adult analysis and pediatric analysis seem to feature quite highly in patients that have been misdiagnosed or diagnosed as autoimmune encephalitis because of fulfilling some of the criteria, either loosely as probable, sorry, possible even, and then occasionally you over-interpret some of the paraclinical investigations and then you give them a probable diagnosis. Okay, so diagnosis is really important. I won't possibly go through the whole talk without at least peripherally mentioning MOGAD, but I know Sunita will talk a little bit about that probably in the context of myelitis as such. The new kid on the block, probably 5 years ago, well characterized now, and the relevance to autoimmune encephalitis is evolving cortical which also was recognized quite some time ago now, where there is a phenotype that mimics meningoencephalitis and a clinical radiological picture that is quite characteristic, and FLAMES has been sort of thrown as an acronym. But the penny really dropped. Again, the Spanish pointed this out when Thais interrogated her first group of patients with autoimmune encephalitis without antibodies. So these are the seronegative group, and identified that in that group, 8% of them were MOG positive. So these were children that we thought had autoimmune encephalitis that was MOG positive. Quite a lot has happened. The Chinese have published quite a lot of papers now on this. And it's very likely that MOG, as it is probably as common, or if not more common, than NMDR. Now, the reason why studies vary is because if you include ADEM MOG as autoimmune encephalitis, it will be as much or more. If you don't include that, then it is probably slightly sort of less. But there are some regional differences as well. If you look at an Asian population where that MOG is not as common, you're going to expect the percentages to be slightly different, almost stacked in favor of NMDR in most Asian and Chinese cohorts, and then equal or more in this cohort, in European, North American cohorts. Okay, so as always, the expanding, cortical phenotype, we've certainly seen a fulminant cerebral edema phenotype. The meningoencephalitis we recognize, already, and on occasions, patients with supra-refractory seizures get given the diagnosis of Ferris or NORS, and then it's more positive, and then do have changes that you can see are flames-like, but maybe, sort of not flames. What is that? And it's certainly in our recent UK cohort that we looked at, 14 or 15% of them would be the cortical, phenotype. So if you think about it, if you look at the adult or pediatric infective encephalitis data and you look at all the unresolved encephalitis in those groups, I reckon that some of them will be MOGAD as well. So if you take all of that together, it is very likely that MOGAD will be or MOG antibodies rather than MOGAD will be the bigger proportion of antibodies if you look at anyone presenting with an acute encephalopathy. Sure, whether when they fulfill autoimmune encephalitis and you don't think there are others, then they're probably less. Okay, so we're going to now move into the innate immune system a little bit more, and this is really, come to fore again after COVID, right? Most of you were sort of, seeing children presenting, and that during a viral sort of infection as such, the three sort of rough mechanisms are essentially the direct invasion, the peri-infectious, which we'll talk about now, and then the post-infectious is, your autoimmune sort of mechanism. And the virus or infection-associated encephalopathy is what we'll feature now. And led by Hiroshi, who described the first, groups of those in Japan many years ago, and Russell, a group of us are trying to make this feel simpler as such. And up till now, these are the recognized sort of syndromes, and some obviously have a more inflammatory phenotype and some have a more excitotoxic phenotype. And we're just going to focus on ANE, which is acute necrotizing encephalopathy, because it is a very, very severe condition, easy to recognize, less controversial as such. We're definitely not going to touch Ferris, as I call it, or virus, because I will probably get my head bitten off by half the Ferris experts for even in suggesting that it might be within the infection triggered encephalopathy sort of syndrome. So what we did was via a Delphi process, agreed a starting criteria for a lot of these patients, i.e. a clinical criteria right at the outset, and 4 recognizable clinical radiological syndromes, and then the rest we fit into each of these as such, and then we park the other 2, as we said, somewhere because it's worthy of mention, but don't want to upset the field as such. And acute necrotizing encephalopathy, as you see there, most severe bithalamic changes, and patients are unwell. The classic treatment for that is, like all conditions, steroids, IVIG, neuroprotection, and the Asians who've been at this for a long time, because they've seen a lot more of those than we do. They do get the more severe phenotype as well, have been using tocilizumab almost within 48 hours of making the diagnosis. They report an improvement in mortality in most of the data to date, but the outcome is still exceptionally sort of dismal for these patients. So working with our sort of wider sort of Asian colleagues, Velda and parents are from Singapore, have pooled a group of 63 children together, and I'm sharing this data with you that is yet to be published, so just be mindful of that. But they were happy for me to share this. They asked 3 questions. The first is whether the addition of tocilizumab improved neurological outcomes in children with ANE. They compared this to the Japanese cohort that was published already. So the Japanese in that cohort also stratified the patients to a severity score, which has been used subsequently, but never really sort of validated in any other cohort. So you can see there that this Asian cohort, that people were giving tocilizumab as standard of care because they were just not doing anything else, was certainly of the more severe, phenotype as well. So the ANE score of greater than 5, and this is what the ANE score sort of looks like. Bottom line is that if you've got shock, if you've got systemic sort of involvement, your score is almost certainly sort of 5. And in the Japanese data, a score of 5 was highly predictive of death, as such. So this is how they compared. MRS, as you know, not the best, outcome, score in children at all, but it is used, and the percentage is significantly, sort of higher. Then what they tried to do was stratify based on timing, and this was the natural graph of how they were giving, tocilizumab. So most were given it within, 2 or 3 days. So we could only use this, component here to measure rather than all those out there. And using the 38, they thought maybe it should be about sort of 2.5 to 3 days. So meaning that as you're giving it outside that window, you're seeing sort of deleterious sort of effect already. I'm just going to share with you the 72-hour stratification that they've done. And this is clearly sort of different. So in addition to giving tocilizumab, you should be giving tocilizumab a little bit sooner. What they're trying to do now is to propensity match based on ANESS score with the Japanese cohort. And I think that will be stronger data demonstrating that you should manage based on how severe it is, how you present, and how quickly as such. Okay, so I hope that gives you sort of at least a sort of compelling sort of reason to start to think of inflammation slightly differently. If you have an autoimmune encephalitis, first line is pretty similar. You would then go down escalating to maybe sort of retux. If you have an autoinflammatory encephalitis, maybe we should be thinking about tocilizumab and anakinra sort of a lot quicker. We probably all do that already, but don't have the framework and courage to say, okay, this is why we think we should be doing that. And of course, many of you will know that in patients with MOGAD, particularly the cortical MOGAD, there's a lot of systemic inflammation. Patients' ESR is usually quite high. They're usually quite sort of febrile. And there have been a few case reports from Brenda's group, at least 2 cases of cortical MOGAD responding well to tocilizumab. So we might need to be thinking about that as such. Okay, so this is the second thing we should do, and that is treating early, as we know there. So beyond diagnosing early, treating early, and then escalating adequately. I'm going to, in the next 10 minutes, just going to take you through some data across conditions. I think we can share some themes, but always recognizing that there's going to be an outlier. And in my sort of slightly sort of older days, I've come back to sort of reading literature that you have to that they scanned into the as PDFs rather than having the word sort of document, and you're going to get it peppered or spiced maybe across this talk, but this is the first of them. And some of you may recognize some of the authors here. Daryl DeVivo certainly is one I sort of recognize. And this remains one of the few papers up till recently to demonstrate the effect of steroids in encephalomyelitis in childhood. And I just wanted to highlight 2 points to you there. One is one we can't do anymore, which is obviously recognizing the natural history, but also being able to recognize the natural history to intervene at the time where you would have extra certainty that it would be effective. And this was 2 to 4 weeks. So these children were left 2 to 4 weeks and then started on steroids, and then they improved. And of course, they stress that there needs to be a sort of controlled study, which to date there isn't one as such. So what are the data there is? Big cohorts is what we sort of have data for, and this is still probably the biggest cohort of NMDR encephalitis, about 500 children, 500 adults, about 200 children. And this is in the inflammation world, we call it the titelogram. And in my sad life, I think it's the Mona Lisa, because every time I look at it, something different, jumps out at me. But the 4, panels there, A is every child, B is all children given, or all adults given, and children given first-line immunotherapy and improving. The key bit there is panel C and D. C is not improving and not gotten second line, and D is not improving but got second line. And all you need to do is visualize that, the white bits are good improvement and then the red is bad. And you can see that, there's a directional sort of change, there as such. Then we've done similar in rituximab. I think some of you would have contributed to this data, about 140, sort of children where we would escalate them at different time points. And there's definitely a reduction of disability as measured by MRS across brain inflammation. So we would use it. And then there's this evolving data on antibody sort of mediated syndromes. This is optic neuritis data. And this is adult data. I'm stressing that whether it can be applied to children or not is debatable, but there's no harm applying, I think, in my view, the same adult timeline I'll explain to you in the next slide. So a 4-day delay in steroids incurs a loss of chance of full recovery as well. So again, I'm stressing on full recovery here because we're very focused on minimizing disability rather than maximizing full recovery sort of overall. And then the short time to initiating plasma exchange is the one that is, I think, the game changer, but there's a caveat there. So there's now, I think, 3 studies, but this is the first, and it's a French one, looking at observationally though, that plasma exchange, when initiated, has its maximal benefit in the first 5 days and virtually no benefit after sort of 3 weeks. And if you think already that our usual paradigm is steroids, 3 or 4 days, IVIG, depends who you ask, might take 5 or 10 days to work, and then you decide on plasma exchange, and that is instituted between the 2nd and 3rd week at the time point where it is least effective already. A slightly different take, a slightly different angle, and this is the Argentinian data that Sylvie curated. Looking at children, it's a slightly different study, so you really cannot compare, like for like. But instead, what they did was that they treated children from 3 days to 186 days. So even up to 6 months, these children were sort of responsive. And I think the only logical way to interpret or to use this data is to use that window to initiate treatment, and don't give up even if you've missed that window, as a lot of my healthcare colleagues always tell me, saying, we've missed that window, so there's no point sort of giving. No, give it. So I think that's my message, at least. Then there's this sort of evolving story in particularly MOGAD, that the early steroid treatment within 7 days in the Italian sort of data, and then adult, much larger sort of data set, stratified to 5 and intermediate 5 to 14 days, and then late afterwards would reduce chances of a relapsing course. So that's a sort of game changer in itself we need to think about. And then there's the evolving data, which I've not presented here because I don't think I understand it yet, of the duration of steroid taper reducing the risk. I certainly would accept that the duration of steroid taper may prevent a patient presenting with a relapsing course initially, whether it does it sort of significantly later. But that data appears to sort of suggest that as well, but it's evolving because most of MOGAD data at the moment is centered on very biased data where institutions have been referred more refractory patients. I don't think we have robust data yet at time point 0 where you present with the first sort of demyelinating event. But maybe Sunita might touch on that a little bit later in her talk. We haven't orchestrated this at all. So obviously there is a need for a control data, but I failed dismally in my last 10 years. I was the chief investigator of an IVIG in transverse myelitis study and the neurology lead for an IVIG and encephalitis study. Both did not meet endpoint because neurologists like us say we must treat with IVIG as such. So I've given up. So in that situation, would real-world data inform us, more whilst we sort of wait? And this is not so much real-world data, and in fact, real-world data, I think, is sort of quite overused, as such. But what I mean here is that in the absence of randomized controlled trials and individualized patient data that then is systematically reviewed and analyzed, give you as much or as best an information. And this is used quite a lot in cancer, quite a lot in rare sort of conditions. So I'll give you 3 examples of how we're starting to use that now. You've probably seen this NMDR sort of paper that was published 2-3 years ago now, sort of looking at all patients presenting with NMDR encephalitis. You have to be very careful with such data because there's a significant likelihood of publishing atypical phenotypes, particularly with individual sort of case reports as such, but it's still the best. So what we did find from the meta-analysis, it does include a lot of data imputation and stats that I do not understand, that I'm told is reliable by our statistician, that there is a clear benefit, as you can see there, from first line sort of therapy, but you can't disentangle the two just because people give it one or the other or both. There is an increase in second line treatment, particularly rituximab being given, and that probably is the explanation for the drop in relapse rate that we notice in patients. And over a period of 60 days, and this was a post-hoc analysis actually requested by the reviewer because our statistician did not allow that, but it got into the paper because the reviewer requested it. That stratified at sort of 60 days, there was an improvement in outcome disability. So this made its way into the consensus review that a lot of you would have read. None of the hard points were in here because a lot of it is still consensus agreed by Adelphi as such. We've just recently published the systematic review on incidence in sort of Korea. Same amount of patients actually, 1,500. Immunotherapy, no surprise, corticosteroids, antibiotics, and valproate were sort of beneficial. Remember, some is in reducing disease duration and some is in preventing sort of relapse as such. And then the bads, and this is the dangers of systematic review and meta-analysis. They're confounders. Plasma exchange doesn't make it worse. It's worse because you plasma exchange very severe patients. Well, I hope. And then we talked about sort of the limitations already. And then this is for as I said, my liking for all literature that I cannot find. So as part of the literature review, we identified this cohort of more than 1,000 patients with rheumatic fever. So I made Michael go to the library and photocopy that so that I could present this to you all. It was just to show that our 1,500 patients and that 1,000 cohort from the 50s and 60s. The Guy's Hospital reports is a little bit like the Massachusetts one here, and it fizzled out in the 70s because the NHS was formed and everyone was stuck and trying to deliver clinical service rather than write reports within a hospital. But Paul Lessoff was an adult rheumatologist. So it was just to show you that the demographics, the clinical course and outcome, i.e. improving after 3 months or 2.5 to 3 months, and the subsequent sort of relapsing course are near identical in the 2 cohorts, almost 60 to 70 years apart. It probably took him longer to do it than us, but I did try to get in touch with him because he was part of our institution to actually write a sort of commentary on this, but he sadly died 2 months after we published that paper. I found his obituary rather than his email address. Okay, so we're completing this systematic review with a consensus now, internationally. And then you sort of see the theme now that we're doing similar with the infection-triggered encephalopathy syndrome, and its early stages of analyzing nearly 2,000 cases. The real question here is whether we go for specific syndromes, whether we do it as a whole, etc. But I wanted to then end this component of the talk by reminding you the 4 epochs that are there that I pointed out. Leech treatment, cold water treatment, thermo treatment were all thought to be the best thing since sliced bread in this era. And just to remind you that despite us thinking that the consensus treatment is the correct thing to do based on all that data now, we really do need sort of more data. We need either proper controlled trials or we need good registry data. And I cannot, stress that. But any of you that have had registry or attempted to do registry data will see, the huge, sort of challenges, as such. Okay, so hopefully moving on to the sort of final, third of the talk is, of course, me as an inflammation expert telling you that, in fact, most of the time it's not, always due to inflammation. And that's always important for two reasons. One is that every inflammatory molecule that you see will have a neurobiological sort of role, either in development or sort of downstream. So the perturbations that you find or mild perturbations that you find in inflammatory cytokines in someone with a neurodevelopmental condition is almost certainly secondary to that neurodevelopmental process, not due to inflammation. I'm looking around just to see if anyone really sort of disagrees with that statement as such. And I cannot recommend any article better than this one, written by my colleague Tom, who's an academic psychiatrist. Demonstrating that the reductionist sort of concepts over the years of making everything inflammation, initially in psychiatry and everything else in sort of medicine, as being extremely sort of dangerous for two reasons. One, that patients are on treatment, and secondly, for those reasons that I told you already, that inflammation is a physiological reparatory sort of process as well. So reductionist calling it inflammation might be fine, but treating it as inflammation is clearly sort of harmful for that reason that I sort of mentioned sort of there. When the inflammation happens, I think it's also important, and this is a concept I wanted to sort of introduce to your group, although you may be familiar with that already. And this is the fetal maternal immune activation sort of syndrome. I prefer fetal because I don't think we can keep blaming the mothers all the time, who are continuing to blame themselves already as such. So the myasthenia group have happily adopted that. Now we call it the fetal acetylcholine inactivation syndrome. So my colleagues, Heinz Jungblut, some of you may know him from the neuromuscular sort of world, and Angela Vincent, everybody knows Angela, Vincent is the first to describe this. So the message here is that the treatment for this is the neuromuscular transmission enhancement with salbutamol, not immune treatment in the child. Of course, if you want to intervene, you might consider doing that in the mother, and there are a whole host of other sort of treatments available now, like your natal FC receptor blockade, sort of, etc., etc. Now, is that developing in the brain, as such? And this is a paper from Russell's group. Some of you may have heard him speak about this already, that in a whole host of conditions, he's going to, we hope, publish the one on PANS, soon. This concept that the maternal immunity is what primes the brain of the children to then subsequently have these, sort of phenotypes. We were asked to provide a commentary for this paper and propose that the responsivity of these patients to infection towards their phenotype. So autistic patients getting a lot worse during infection, PANS patients getting a lot worse during infection due to this early priming of the microglia at the outset. And Russell's will change that to fetal immune activation syndrome. And it's a very nice review by Velder in himself. And Velder, as you may have recognized, is actually the same Velder as the ANAC sort of paper. So she did a stint with Russell developing this. So I think this is going to be what we would be thinking about. And this would be very much of a feature of the folate sort of receptor, sort of antibody story as well in patients with just about any neurodevelopmental condition. Okay, so what is the pathology? Again, this is down to why it's not necessarily inflammation all the time. This is the best, could have made it a little bit bigger, but this is the acetylcholine receptor, but you could replace that with NMDR, you can replace that with thyroid. The three key ways to think about it. One is that it sits on the receptor, so it either blocks or activates, the receptor. Then there is receptor internalization, so you usually lose the function as a result of that. And that's why you have NMDR, dysfunction for such a long time. It's a loss of function. And then obviously in some conditions where they're either opposed together or there's a sort of enriched milieu, it complement activates. And once you complement activate, there is a necrosis, there's a lysis sort of version for that. that rarely happens in autoimmune encephalitis, except in some, forms of autoimmune, sort of encephalitis. But predominantly, the main, sort of mechanisms are in loss of function. And this is a nice review, an adult, based review. And many, studies have now looked at how you enhance transmissions to improve the symptomatology as such. If you thought that this was an immune, mechanism, there are numerous, new targets, more monoclonals, more biologic than we can mention, and I'm not going to mention it in this talk. I just wanted to highlight vamorolone, this group. I know that you've got a very big sort of neuromuscular, strength here. Vamorolone is now recognized as a treatment, and it's been licensed even in the UK, so it must work. So by knocking out the sort of delta 9 and 11 ring on the steroid ring, it appears to incur a benefit in safety whilst maintaining the immunoinflammatory response. So this is the steroid without the steroid side effect. And I have been in touch with Eric about 4 times now, and every time the game post changes. One was that, of course, in the early days, the safety studies were all done in boys because of this differential. We don't have as much safety data in girls and sort of women, so they've improved on that now. But they've decided that they're going to pick a disease like asthma or something that's slightly far more common. But it would be ideal if we could, at least convince them to start a small study on a small group of patients with neuroinflammation, because I think this would have a major sort of, benefit above and beyond all the other, biologics as such. Okay. Blood-brain barrier in decision making. 3 things you have to think about. Do the drugs get into the brain, right? We talked about that. The second is there an inflammatory component in the brain that you preferentially want to get the drug into the brain to treat? And this is the intrathecal methotrexate, story that we borrow from our oncology colleagues, which we should still use. And there has been only one sort of case report for that of 3 patients, but I've certainly heard a lot from colleagues, particularly in sort of Asia, where that would be used in the days that rituximab was more expensive. Once rituximab, once we had the biosimilars, everyone had switched to using, sort of the biosimilars as such. So it's another example of how, things change not because of biology, but because of, availability of, treatments as such. I'm just trying to make sure I keep the time, and probably we'll do another 10 minutes if that's okay. So this is the blood-brain barrier, sort of 5 minutes, okay. And essentially, that the all IgG sort of passage into the brain is either passive, or it's made in the brain, and you measure it by criteria that if you have the same amount of albumin ratio as such, so it's usually about 1 in 300. So if you draw the line of 1 in 300, I've been a bit sort of allowing for extra, which is 1 in 500. You can see that at aquaporin 4, MOG, and probably LGI1, which is observationally what we see. Everything is outside the brain, and then the rest, all the neuronal surface, one inside the brain. So if you want to target things, then you need to think about targeting things centrally only in those conditions that are intrathecally driving antibodies as such. So this is my last talk here, last 2 slides here that I'm going to talk about, and it's the lymph nodes and the teratomas being the germinal centers of NMDR. We know this because in teratomas, as you know, or in NMDR encephalitis, there's reports of the minute you remove, the teratoma, the patient is significantly sort of better. And then the cervical lymph nodes is what I alluded to a little bit earlier, whereby it's the primary, priming ground. And so what they have shown very elegantly there is that the cervical lymph nodes and teratomas are actually working like, germinal centers. But the clinical relevance of that is really in this paper, and extending that to NMO. So these are patients with aquaporin 4 positive disease. All you need to look at is panel E. Blue are being able to identify IgG antibodies in the lymph nodes, and red is identifying it in the serum. And if you can see there, that first, epoch there is pre-rituximab, then the second epoch is after the first rituximab, and the third epoch is as you go on to treat, but some patients are repleting in the lymph nodes and in one of the two, so only 50%, so it could still be chance, but it's highlighted in that paper that the patient then relapse. So is the repleting in the lymph node the biomarker that we need for identifying groups of patients that go on to have relapsing sort of disease? Aquaporin 4 is a proof of principle. It's a well-treated, sort of condition. We know that patients don't really relapse after being put on rituximab. But if you extend that to MOGAD, where we know that patients relapse despite, being put on treatment, might that be a better, sort of disease? So I think I probably will just end there now, because otherwise I would sort of go on, forever. So I hope to have illustrated to you that, in this whole, host of conditions, the rationale for, diagnosing, treating earlier, and thinking slightly differently is going to make us change, the way we manage autoimmune conditions and a whole host of autoinflammatory conditions. Thank you.
Thank you very much. And I was anxious to get up here because I wrote down about 12 questions, and I'm assuming there's a lot of questions. We only have a couple of minutes for questions, but who's got the most burning question they want to ask? That was a wonderful talk, by the way. Asif.
So I do have a lot of questions, but I'll just do one. I'll talk to you later about some of the other ones. But the research you showed from Russell Dale, looking at that maternal factors that influence the others. So what does that imply about treatment? Because obviously a lot of these patients, PANS patients,
yeah. So for me, for the PANS patients, unless you are going for an alternative microglial type strategy, and autoimmune strategy like steroids, etc., will not sort of work. Steroids, of course, is a different ball game because it has so many effects, right? It might have an effect on membrane stability, like you find in the Vermeerlone paper. So that might, in fact, help in the brain, and it will have microglial sort of effects. A lot of people think that the antibiotics probably mediated that way as well, particularly all the macrolides, as such. So I think that's the message. Whether you can moderate the immune system in the mother. So these are all mothers with autoimmunity. These are mothers with a high risk of that. I think you just got to treat the primary condition as such, because they're so sort of varied. But if you think that neurodevelopmental conditions are 10% of the population collectively, you're not going to be treating everybody with that. So it's just an understanding of the mechanism, and I think that provides robust ways of making sure we move away from this reductionist everything is inflammation paradigm.
Any other questions? Maybe I can ask one of my questions. The very first one I wrote down was in one of your early slides, you were talking about the Fc receptor at the blood-brain barrier and the role both in importing and exporting, maybe re-exporting antibodies, including kind of a detoxification type mechanism. Is there any specificity to that in terms of the antibodies that are being removed from the blood-brain barrier, or is it a pure kinetic?
It's a pure blanket,
So it's just the abundance of the antibody to be a competitive.
And you would like to think that if it's for a pathogenic one, it shouldn't be a major problem, as such, because the amounts in your brain is not going to be that much, because the relative amount of clearing are the other, sort of antibodies. I looked up the most recent review on Fc receptors and where they are sort of currently being investigated, and luckily no one's trying to do it on sort of CNS autoimmunity yet. So I think they're probably recognizing that there could be potential negative effects. That's why everything's, CIDP, myasthenia, all are very peripheral syndromes.
And is there any genetic Fc receptor or Fc variation that has been associated with risk or with severity of
So not the autoimmune encephalitides as such, because as you know, autoimmune encephalitis is very tiny in the numbers, so you're not going to get a strength. The only good paper that I found is the FC receptor polymorphism that increases your upregulation of IVIG and hence your recycling of rituximab and potentially biologics. And there was a nice sort of Korean paper. But again, because it's so cheap now, you just measure the alternatives rather than the polymorphism, which is probably less predictable than measuring the biological effects of it.
Great. Oh, there is a question online. Maybe we'll take that as our last question. There is a question? A hand. Okay. If someone has their hand up, if you can unmute and ask the question, we'll make that the last question. That's for the people online. I don't think I'm seeing one. Okay. So with that, maybe we'll close out the session. And again, I want to thank you very much. Wonderful grand rounds. And if anyone hasn't listed 12 questions that they want to ask, speak to Dr. Lim. Thank you again.